Wait, can I still get pregnant in perimenopause? Here's the part no one tells you. Perimenopause is not an off switch. Your periods get unpredictable, your symptoms get weird, and yes, ovulation can still pop up like a surprise guest at a barbecue. Translation: pregnancy is still possible until menopause is confirmed. That's 12 full months without a period. In the US, the average age of menopause is around 51, 52, but the timing varies a lot. So, if you don't want to conceive, you still need contraception. If you do, timing and good info matter. What perimenopause really is. Let's decode the lingo in plain English. Perimenopause is the multi-year transition leading up to menopause. Experts use the straw-10 system to describe it. In early transition, your cycle starts to wander, usually by at least 7 days from your old normal. In late transition, you may skip cycles, with gaps of 60 days or more between bleeds. Menopause itself is confirmed after 12 continuous months without a period. Post-menopause is everything after that. None of this is a neat on-off switch. Hormones and ovulation can flicker during the transition, which explains why symptoms and fertility both feel unpredictable. Knowing these stages helps you plan. Contraception if you want to avoid pregnancy, earlier evaluation if you're trying to conceive, and smart symptom care throughout. Age versus fertility. Fertility is about probability, not perfection. In your late 20s and early 30s, the chance of conceiving over a year is high for most couples. As age increases, the per-cycle chance drops, and it takes longer on average to conceive. Large cohort studies show that by 12 months of trying, cumulative pregnancy chances are lower at ages 40, 45 than at 25, 29, even when couples are otherwise healthy. That doesn't mean impossible. It means the odds are smaller and the timeline longer. There's also biology we can't see. Egg quality changes with age. That's why miscarriage risk rises with maternal age. The lowest average risk sits around the late 20s and climbs steadily into the 40s. This isn't your fault. It's how human reproduction works. Knowing this helps you set realistic plans and timelines instead of relying on myths or celebrity headlines. One more piece. Paternal age. It generally has a smaller effect on getting pregnant than maternal age, but older paternal age is linked with some risks and changes in semen parameters. It's not a panic button, just context to include in planning and counseling, especially if both partners are older. The real timeline, decade by decade. From a big picture view, the late 20s through early 30s are the easiest time to conceive for most people. In the mid to late 30s, the monthly odds begin to fall faster, and time to pregnancy stretches. In the early 40s, ovulation still happens but less reliably, and embryos are more likely to be chromosomally abnormal, which lowers live birth chances and raises miscarriage risk. After 45, spontaneous conception becomes rare, not zero, until menopause is confirmed. That's why you'll hear two seemingly opposite truths. You can still get pregnant in perimenopause, and natural conception at 45 plus is uncommon. Both can be true at once. If you're trying, that doesn't mean you're powerless. It means you work with the clock, not against it. Learn your fertile window, consider earlier evaluation as you age, and think through backup plans. If you're not trying, don't assume irregular cycles equal infertility. Perimenopause can still surprise you with an ovulation and a positive test when you least expect it. AMH, FSH, AFC, and APS. Helpful tools or false comfort? You've probably seen ads for fertility tests. Here's the straight talk. AMH, anti-Müllerian hormone, and AFC, antral follicle count, give a sense of egg supply, not egg quality. They're useful for planning treatments like IVF because they hint at how many eggs you might retrieve. But for people trying naturally, low AMH alone does not reliably predict whether you can get pregnant soon. That's been shown in high-quality studies of women in their 30s and early 40s. Don't let a single number steal your hope or give false reassurance. Age still outscores any one lab when it comes to natural fertility. There's another curveball. Hormonal birth control can temporarily lower AMH and suppress AFC while you're using it, which can make your reserve look worse than it truly is. If possible, some clinics will recheck after a short break before big decisions. That's about test interpretation, not about birth control being bad. Cycle tracking apps can help time intercourse, but during perimenopause, your cycles may be irregular, so apps are less reliable than earlier in life. If pregnancy is the goal, pairing tracking with ovulation testing or professional guidance can help. Want kids now? When to try, when to get help, what to expect. If you're under 35 and have tried for a year without success, it's time for an evaluation. If you're 35 or older, check in after 6 months. Go sooner if you have red flags like very irregular cycles, known fibroids or tubal disease, endometriosis, or a history of pelvic infection. That early visit doesn't commit you to treatment, it gives you a game plan. What might that plan include? Sometimes it's as simple as better timing. Sometimes it's medication to trigger ovulation, intrauterine insemination, IUI, or moving to in vitro fertilization, IVF. National surveillance shows that assisted reproduction helps many families each year. But success rates vary strongly by age and whether you're using your own eggs or donor eggs. Your clinic can pull the latest numbers for your age group and situation so you know the real odds, not the Instagram version. If you're feeling stressed reading this, that's normal. Take it one step at a time. Information, options, support. Hope and realism can live in the same room. Egg freezing. Egg freezing is best thought of as insurance with a deductible. It helps many, but it's not a guarantee. Most professional groups consider it ethically appropriate and a reasonable option when childbearing is being delayed. In general, the younger your eggs when you freeze them, the better their potential later. Clinics estimate how many mature eggs to aim for based on age and personal factors. That target is about giving you a meaningful chance at a live birth later, not a promise. Also good to know, if you've been on long-term hormonal contraception, your ultrasound counts may look lower while suppressed. That's reversible, and some programs build in a short pause before stimulation so they can size up your baseline more accurately. Again, that's about test optics, not moral judgment on your contraception history. If this is on your mind, ask for a consult and bring your questions about success rates at your age, costs, storage, and realistic next steps. You can still get pregnant. If pregnancy is not your goal, keep using contraception until menopause is confirmed. U.S. guidance emphasizes that ovulation can still occur during perimenopause, even with skipped periods. Many methods are appropriate for healthy midlife users. Clinicians use the CDC's medical eligibility criteria to match methods with medical history. For some people on progestin-only methods who have no bleeding, checking FSH twice can help confirm menopause. Others choose to continue contraception until their mid-50s when natural infertility is highly likely. Your clinician can personalize this based on health risks and preferences. Short version, don't let irregular cycles trick you. Whether you're 42 or 52, talk to your clinician about a safe, effective method you actually like, and a clear plan for when to stop. Premature ovarian insufficiency. POI means loss of normal ovarian function before 40. It's uncommon but important because it affects fertility and long-term health. Some people with POI still ovulate occasionally and can conceive, sometimes with assistance, others use donor eggs. Outside of fertility, most major guidelines recommend hormone therapy, if no contraindications, to protect bones, heart, sexual health, and quality of life until at least the average age of natural menopause. If your periods have become very irregular or stopped early, get evaluated. Don't assume it's just stress. Myth busting and smart next steps. Myth 1. AMH tells me if I can get pregnant this month. It doesn't. AMH is about egg quantity and is useful for IVF planning, but it's a poor crystal ball for natural fertility. Myth 2. IVF fully cancels out age. Age still matters a lot for success with your own eggs. Donor eggs change the math, but that's a different path. Myth 3. If my periods are wonky, I can't get pregnant. Perimenopause equals unpredictability, not guaranteed infertility. Here's the practical takeaway. If you want pregnancy soon, time intercourse, consider earlier evaluation as you get older, and use real data to guide choices. If you don't want pregnancy, choose contraception you'll actually use and make a plan to stop safely. Above all, ditch the shame. Bodies change. Good info helps you adapt. If this helped, jump into the comments and tell us what you wish you'd known earlier about perimenopause and fertility. Ask questions. Share what worked and what didn't. Let's make this channel a real community where women in midlife find recognition, practical tips, and solid science, and where we've got each other's backs.